everyone. I'm Emily. I'm a fourth-year medical student. I just want to encourage anyone in the crowd, if you have any suggestions, if you want to throw them in the chat, I'll be keeping an eye on that. Obviously, I've never done this before, so very grateful to be here.
Sometimes he ends up in the hospital. He often ends up in the emergency room, especially when his home albuterol puffer inhaler runs out. His grandmom is standing outside the ICU.
And then have we given any steroids at all?
No, great suggestion. He has not gotten any steroids at all. Mitch is putting in an IV for you, and we can get some Solu-Medrol over. So yeah, Jeff has a Yankauer suction up there. He can definitely make sure there's no secretions and suction him out for you real quick.
Perfect.
Solu-Medrol's given.
Would we consider magnesium sulfate in this kiddo?
Absolutely. So I actually have some mag right here that I can hand over to Mitch.
I don't know if a gas is possible. And then if we have like portable chest radiograph, it'd be great to check for any actual like focal consolidation just to rule that out versus an asthma exacerbation.
Yep, absolutely. So here is his CBC.
Oh, wow. Okay.
The ER drew that. So intubating an asthmatic often can exacerbate your problem and make things a little bit worse and a little harder on you. So sometimes we may have an interim step, and I'm going to hand this to Mitch, where we might give them BiPAP, which is still positive pressure, but non-invasive. Patient gets terbutaline, they're usually fully awake and alert. So if you come at them with a bag and mask and a laryngoscope, they're not going to be happy.
We have a ketamine in the chat.
Absolutely. So ketamine is probably the best choice and the classic drug. So Mitch, why don't we draw up 1 per kilo of ketamine, 2 separate syringes of that, and we can induce anesthetic. And we're going to want to neuromuscularly block this patient as well. In pediatrics, we often use either VEC 0.1 per kilo or rocuronium. So why don't we get some rock? And then Jeff can take us through some of the steps of intubating our patient. And then we'll stop our code and do a debrief. So for those of you who have seen these recordings that I've done with my residents and fellows, welcome back to another one, and you'll get to experience it in person. For those of you who haven't seen it before, I can kind of give you a quick walkthrough on how this works and how this looks. But basically, we set up a remote camera at the foot of the bed that we can broadcast in Zoom, and you're in what's kind of the traditional standard mock code leader position. So the mock code leader is not the person that should be doing chest compressions or intubating the patient or giving any of the meds. We have confederates and assistants that could do that, residents and fellows and nurses and respiratory therapists. So Jeff and Mitch are going to serve as some of those people for us today. And we want you to be able to see the patient, see the entire room, see the monitor, which can change in real time in Acadicus. So the saturations can fall, the blood pressure can go up or down, the heart rate can go up or down, the rhythm can change, the respiratory rate can change, the patient can seize. Our mannequins in Acadicus can be bag mask ventilated, they can be intubated, they can have a chest tube put in, they can have IVs put in, they can have central line put in, they could be put on a ventilator. So there's lots of things that they can do. The other thing to be aware of is that if there's something that you need or want, so I want a blood gas, or I want an X-ray, or I want a CAT scan, or I want an echocardiogram, we have all that built into Acadicus as well. Not every scenario is exactly the same, but if we have it, we'll give that information to you as well. And, you know, we talked with Emily beforehand as the code leader. So if she wants us to give the patient oxygen or give the patient volume or give an antibiotic or give some epi or give an albuterol, if we have it and it's part of the scenario and it makes sense, we will execute those wishes. So at this point, why don't I give a quick introduction that this is Ryan. He is a 10-year-old child. He's got a history of every time he gets a cold, he starts to have some wheezing. Sometimes he ends up in the hospital. He often ends up in the emergency room, especially when his home albuterol puffer inhaler runs out. His grandmom is standing outside the ICU. He's been admitted to the ICU once in this past year when he had some RSV back in December. He caught COVID one time and had to come to the emergency room. And this most recent time, same kind of story. Grandmom says he had a low-grade temperature. He started to have a runny nose and cough, and then he got short of breath. She ran out of his albuterol. She brought him to the emergency room. In our emergency room, they recognized that he was having some trouble breathing, and they pretty quickly moved him up to the ICU after 3 back-to-back duonebs, which is albuterol and Atrovent. His current vital signs are displayed up on the monitor. So his heart rate's 129. In room air, his saturation is 93%. He's pretty tachypnic at 38 breaths a minute. He has a blood pressure of 108/52, so a little bit of a wide pulse pressure. And you can suspend disbelief. He has an arterial waveform pulse monitor there, but we really just took that off of his cuff. That's his blood pressure from the cuff. So Emily, why don't I turn it over to you? You can ask for more history. You could have Jeff and Mitch start to execute some of your wishes. We can go from there.
Okay, just want to quickly, hey everyone, I'm Emily. I'm a 4th-year medical student. I just want to encourage anyone in the crowd, if you have any suggestions, if you want to throw them in the chat, I'll be keeping an eye on that. Obviously, I've never done this before, so very grateful to be here. Okay, so I definitely want to start with just getting a little bit more history. It sounds like he has albuterol at home, so he has known asthma.
He does.
Is that right?
Correct.
Okay, and is he awake and alert? I can see that the mannequin is laying down.
Yeah, he was sitting up, but when we first got in here, Jeff recognized that he looks a little sleepy. So he laid him down and he's getting some equipment together in case things go wrong.
Okay, yeah. So is that his respiratory rate, the 38 on the back? I would definitely rotate and just observe that respiratory rate and just have everything ready for like another airway, or just in case, just because he's breathing a little bit quickly. He's at 93%, which is good. And
so Jeff can definitely listen for you and give you a report on his breath sounds.
Cool, perfect.
What do you hear, Jeff? What does he sound like to you? Grandmom said he was wheezing a lot at home.
I think we still have some wheezing.
So he's pretty tight.
Yeah.
So I'm not sure, we gave albuterol, you said we gave, I'm not sure what the next step would be in this situation as far as moving into like ipratropium or another albuterol treatment.
So in the ER, he got the 3 kind of standard back-to-back albuterol Atrovent duoneb combos, but he hasn't had anything since then. And that was about 30 minutes ago or so. So if you want, we can definitely give him another albuterol.
Yeah, I think the only thing I'd be worried about is his heart rate, but he's at 129. So I think that would be appropriate as long as you all feel good about that.
So Jeff can get him on a mask and I'll grab the neb machine for him. We'll just sit that right here on the bed, hook that up to the mask. And how much albuterol? Normal standard for his age and size, probably going to be about 10 milligrams an hour if we want to do a continuous.
I think that's perfect.
Okay, great.
And then have we given any steroids at all?
No, great suggestion. He has not gotten any steroids at all.
Okay, I would love to give him maybe IV dexamethasone. I'm not sure the dose.
So that would be perfect. In a lot of ERs, dexamethasone has become the standard. In our ICU, we still give Solumedrol as a 1 milligram per kilogram IV Q6. But Mitch is putting in an IV for you and we can get some Solumedrol over.
That's perfect. And then I'm assuming we've kind of checked out his airway, just given him like a little suction, maybe consulted RT.
So yeah, Jeff has a Yankauer suction up there. He can definitely make sure there's no secretions and suction him out for you real quick.
Perfect.
Solumedrol's given.
And is that blood pressure, is that like 108?
Go ahead, Emily, you had a question?
Yeah, I'm just having trouble seeing the blood pressure. That's the only vital that I can't quite see. Oh, wow, cool. 108/52. Okay, great.
Okay, so that albuterol is running. Looks like he's got continuous vitals with a couple changes. Heart rate's a little higher, probably due to the albuterol. Sat's a little bit lower at 89. His respiratory rate's a little higher at 44, and he's still got a decent blood pressure, 111/49.
Okay. I am very open to suggestions here. I'm a little bit worried about like that, just sort of increased respiratory rate and the decrease in saturations, even with those interventions.
So anybody from the audience want to open their mic and offer other suggestions for next steps in an asthma type pathway? 3 albuterol Atrovent back-to-backs, on a continuous albuterol now, and also got some loading dose of Solumedrol. Any other options anybody can think of or want to offer up?
Would we consider magnesium sulfate in this kiddo?
Absolutely. So I actually have some mag right here that I can hand over to Mitch. And our standard dose is going to be 25 to 50 milligrams per kilogram, up to a max of 2 grams.
And then sort of, I guess while he's stable, I think it'd be great if we could draw some labs up, maybe just like a CBC, electrolytes. I don't know if a gas is possible. And then if we have like portable chest radiograph, it'd be great to check for any actual like focal consolidation just to rule that out versus an asthma exacerbation.
Yep, absolutely. So here is his CBC.
Oh, wow. Okay.
The ER drew that and it just resulted a couple minutes ago.
Oh, this is very neat.
So let me know when you're done with that and I can give you the next test.
Oh, wow. This is even clearer now. Okay. So white blood cells look good. His hemoglobin's good. Hematocrit's good. Platelets fine. Neutrophils. I'm not sure what the normal range for neutrophils is, honestly. A little high on monos. Okay.
Pretty normal CBC.
So that's kind of making us, okay. So he's kind of that like classic, a little bit hyperinflated. Okay, but obviously no focal consolidation that I'm seeing. I'm not seeing any like pneumos, any broken bones. Heart size is good. I'm not seeing any air under the diaphragm. Okay, great. So this is a pretty normal chest X-ray from what I can see here.
Yep.
Great. Okay, perfect.
And then we do have part of a critical care panel, which in our hospital is a combination of a blood gas and some electrolytes. The electrolytes are normal. I'll read them off to you. Sodium's 135, his potassium is 4.5, his chloride is 101. His hemoglobin and hematocrit come as part of that as well. And they were also on the CBC and are normal. His lactate is about 2.8. So our normal is 2 or less, so a little bit higher. And then the gas part of it is this.
Oh man. Okay. I'm definitely going to need some help on this. So he is he's alkalotic. He's breathing off acid, which makes sense. Is he trapping air? Can someone help me with this one? I'm sorry. I have not.
No, don't be sorry at all. So he has a very low pH, normal 7.4.
Yeah.
He has a very high CO2. So he has a primary respiratory acidosis, kind of goes along with asthma and air trapping, and he's in impending respiratory failure.
Okay.
Probably goes pretty nicely with your x-ray that you already identified as well. Doesn't look like he has pneumonia, but he's air trapped. He's hyperinflated. He can inhale, but he can't exhale very much.
So would we consider intubating even though he's at 89% just because we know he's not doing well, or would we sort of let this play out?
So I think there's a couple options that we can talk about and discuss that would be a good discussion point. So intubating an asthmatic often can exacerbate your problem and make things a little bit worse and a little harder on you. Mm-hmm. So sometimes we may have an interim step, and I'm going to hand this to Mitch, where we might give them BiPAP, which is still positive pressure, but non-invasive. So mask-driven. We can give continuous aerosols through it, like albuterol continuously. So we may be able to give him some positive pressure help, still deliver the continuous albuterol. But what really is going to make the difference in his circumstances, if we kind of survey Jeff and Mitch and say, he's breathing pretty fast. Is he like waking up with a CO2 of 95? Is he kind of obtunded? Is he got a gag when you suction him? Does he have a cough? Is he protecting himself at all? And if the answer is no, there may be a couple brief interventions you could try. Things like subcutaneous epinephrine, terbutaline load, and a terbutaline drip, which is an IV form essentially of a beta agonist like albuterol. But if he doesn't dramatically open up and start to either really wheeze or really move air and move his chest well, he's probably going to force you to intubate him.
That makes
There's
sense.
one advanced step that we use in our ICU that probably is beyond the scope of this, where we could give gas anesthetic. So we have an OR anesthesia machine, and isoflurane is actually a very potent bronchodilator and vasodilator, but you can bronchodilate people and keep them from the end pathway. So Emily, you said you're going to match in pediatrics. Every mock code for the rest of your life, the final step is always ECMO. We're definitely not going to go ECMO in this circumstance. But if Jeff and Mitch think he's not awake enough, maybe we should walk through the steps of intubation as the next step. So what do you guys think?
Yeah, I think so.
Yeah.
Okay, not doing much for you on suctioning, not doing much with sternal rub. So why don't we get ready to intubate? So you guys have your bag and mask up there. You have your laryngoscope. You have an endotracheal tube. We can talk about drugs. So anybody from the audience or Emily, any classic drugs that may help us get over the hump and intubate an asthmatic safely and maybe get us to bronchodilate a little bit? There's one classic one that people often think about.
Would it be atropine, reducing secretions?
So atropine's definitely part of a lot of people's asthma pathway, and it
Racemic.
will reduce secretions for sure. And it may go well with this other drug that causes a lot of secretions, but also may bronchodilate you as well.
Terbutaline.
So TERB is a great bronchodilator, but not much of a sedative in terms of intubating a patient. Patient gets terbutaline, they're usually fully awake and alert. So if you come at them with a bag and mask and a laryngoscope, they're not going to be happy.
We have a ketamine in the chat.
Absolutely. So ketamine is probably the best choice and the classic drug. So Mitch, why don't we draw up 1 per kilo of ketamine, 2 separate syringes of that, and we can induce anesthetic. And we're going to want to neuromuscularly block this patient as well. In pediatrics, we often use either VEC 0.1 per kilo or rocuronium. So why don't we get some rock? And then Jeff can take us through some of the steps of intubating our patient. And then we'll stop our code and do a debrief. So 1 per kilo of ketamine just went in and is getting flushed. And then the rocuronium will go in. We'll need about 60 seconds or so until the patient's fully paralyzed, fully relaxed, less risk of vocal cord spasm or rigid chest phenomenon and those kinds of things. About 60 seconds, making sure that we can move the patient's chest with the bag and mask. We usually will transition them off the BiPAP and go to our bag mask steps at that point, and then we can go through the intubation. Now I'm going to actually come up and help Jeff by handing him some tools. So Jeff's getting pretty good chest rise with our paralysis. Great. All right, so our next step in intubation, he's got good mouth opening, usually with a scissor technique to get the mouth and jaw to open. Now he's going to place our Macintosh blade midline. He's going to lift in the direction of his thumb towards the ceiling to expose the vocal cords. He should be able to see them. I'm going to hand him the endotracheal tube, which we want to come in from the side. So the endotracheal tube doesn't need to and should not block your view of the cords. So there's a channel down the center of the laryngoscope that people often think, oh, well, that's where the tube must go. That channel is for your eye. You want to come in and sneak in from the side with your tube. Sometimes I'll have an assistant pull the lip down so I can get the tube in from the side. Then we're going to pull the stylet next. We've taped to his face. Now we want to confirm, is that tube in? Now, Jeff is a seasoned proceduralist, so he saw it go through the cords. But Emily, any suggestions about how can we know for sure that the tube's in? Is there anything we can do to try to confirm that the tube's in other than Jeff's word that, yeah, I saw it go through the cords, it's in?
Yeah, I think I'm saying this wrong. I've only ever read it, but capnography and that, maybe
So
an
he's got an end title on right now, and he's attaching the bag and mask to the end title.
And then in the chat, we have listen to the lung sounds, which is also a great option.
Yep. So Mitch can pick up our scope and listen for bilateral breath sounds. That's a great one as well. We can look and inspect the chest for equal chest rise. We can look for vapor in the tube as well, although that's anecdotal sometimes. And then if we go back to capnography, let me just make a quick change on our vitals monitor so you guys can see it. We do have electronic end tidal. And once we have a breathing tube in, if you notice our respiratory rate goes from 38 or 44, the rate that we were bagging him at, to a square waveform. And that's the end tidal CO2 that's monitored electronically. You can see the end tidal still pretty high. We knew on the gas it was 90 something. It's 98 right now. If he was an asthmatic, instead of that flat square, it may be a little more shark finned as well. So that's something to keep in mind, that his bronchospasm may not have been relieved just by putting a breathing tube in. We still may have more work to do, like epinephrine, terbutaline load, more steroid, gas anesthetic, ketamine, paralysis, and then eventually ECMO if we can't get his pH and his CO2 under control. One more brief word about the capnography. So when it comes out of the foil package, if you're not using the electronic end tidal, you have a color changer. It's just litmus paper. So it comes out of the package purple. Within 3 to 5 of the breaths that Mitch was applying, that paper will turn from purple to yellow. Yellow means yes. It stays purple. Purple means a problem. So again, just to say, we put the tube in, we saw it go through the cords. That's one confirmation. Auscultation with equal breath sounds is the second. Equal chest rise by inspection, that's the third. Vapor in the tube, that's the fourth. End tidal CO2, that's the fifth. And then finally getting a radiograph afterwards to see exactly where the tip of the tube is. We could be in the right main stem, so that's that important step of making sure the chest is rising equally. And then listening as well. Those are all good ways to try to confirm, is our breathing tube in the proper position. The laryngoscope, we're going to pick based on the angle of the jaw and see that the tip goes somewhere to the mid-trachea, where we would expect the mid-trachea to be, right about here. So we can kind of measure the blade beforehand and say, all right, that's going to be about the proper size for him. The Macintosh blade is curved. It's got a little bevel on the end, or a little barrel on the end. And the idea is to put this in the vallecula above the vocal cords, and then lift that epiglottis trapdoor up by lifting in the direction of the ceiling and the direction of your thumb. So that's just a little brief primer on the Macintosh blade. The tube itself, we want to take the age of the patient plus 16. So we said he was, 10. So 10 plus 16 is 26. And then divide that number by 4. 4 goes into 26 about 6 times. So he would be a 6.0 or a 5.5 cuff tube, somewhere in that range. And then the depth of the tube. So if we picked a 5.0 tube, for example, we want to multiply the size of the tube, the diameter of the tube, times 3. And that's how far we put it into the trachea and tape it at the lip. So the tube will have markings in centimeters along the tube itself. And you can just say, all right, well, that was a 5.0 tube. I want to go to 15 and tape at the lip or the teeth. 6.0 tube would be 3 times 6 is 18. A 7.0 tube would be 21, and so on. So just some kind of extra pointers for intubation and securing the tube properly and making sure that it's in the right position. So last thing before we kind of wrap up this mock code, and this is way beyond general peds, it's way beyond peds residency. This is what I talk to my fellows about. The asthmatic and manipulating the ventilator to help them expire CO2 is very, very different than normal mechanical ventilation, very counterintuitive. So you would think with a carbon dioxide of 98, I would want to crank the ventilator up and breathe fast for the patient, give him 40 breaths per minute, maybe 45 breaths per minute. And what's different about asthma is I want to do less. So I want to manipulate the ventilator to give him less mechanical breaths a minute, maybe 10 to 15. I want to manipulate the inspiratory time on the ventilator to give it a maximum amount of exhalation time. So that's the I to E ratio. So for every 1 breath in, I want him to have enough time for 4 breaths out. And if I give him 40 breaths a minute in an effort to blow down that CO2, the ventilator malfunctions. It can't do that 1-to-4 ratio that I want. So I've got to actually turn down the mechanical ventilator rate, which again, doesn't make sense to the ear or the eye when you say, well, CO2 is 98. Why would you give them less breaths a minute? It's all about I to E ratio. The standard tidal volume for most ventilated patients is 6 cc's per kilo of tidal volume. So if he was 10 kilograms, I'd give him 10 times 6, 60. In his case, he's going to be more than that. He'd be 25 to 30 kilograms. But 6 cc per kilo tidal volume in an asthmatic may not stent the airway open enough. So I may actually give a little bit higher tidal volume, an 8 cc per kilo tidal volume. The PEEP, as that X-ray showed and Emily pointed out, really hyperinflated and air trapped. He's already got a lot of auto PEEP. So I may give him a lesser PEEP. I may give him a PEEP of 3, may give him a PEEP of 0 instead of the standard PEEP of 5. And then the FiO2, the oxygen titration, we always start at 100 when you first get intubated, and then we try to titrate to less than 60% for oxygen toxicity. So I have a couple other debrief slides. John, if you wanted to bring the camera out into the main part of the PICU, we can wrap up and then we can do our tour. So just a couple slides that are pretty basic, but make a lot of sense for the asthmatic. So on the far left, normal airway, no bronchospasm. The muscles are relaxed. The smooth muscles are not constricted. On the far right, you have an asthmatic airway. So notice that the muscles have tightened and kind of constricted like a boa constrictor around the airway. The airway has narrowed down to the star shape, and there's inflammation, maybe because he's got rhinovirus or RSV or some other comorbidity that's causing him to have a flare. And then he's going to have increased mucus production as well that's going to plug up that diameter. So we go from something that's nice and open with no mucus, no inflammation, to something that's really narrow. You can see and envision in your mind how you could get air in there with a ventilator. But how's that air going to get back out with all this smooth muscle contraction? So everything that we can do from our therapies, bronchodilate with albuterol, bronchodilate with Atrovent, bronchodilate with ketamine, smooth muscle relax with magnesium, reduce inflammation and the inflammatory response with steroid, suction and provide pulmonary hygiene for the mucus production. If we can get rid of a lot of that, that's when you have success with breaking the asthmatic and improving their outcome. And then just a quick graphic that I want to go over that's important. So in mechanically ventilated asthmatics, our respiratory therapists usually get very intense and wrapped up about the peak inspiratory pressure is high. You asked me to deliver 6 or 8 cc's per kilo, maybe that's 300 cc's of tidal volume, but the ventilator is doing a lot of work. It's using a lot of pressure to push that air in because they're so bronchospastic. It's alarming. And in pressure regulated volume control mode that we like to use, the ventilator will dump that breath and say, well, you're not getting the 300 that you think you're getting because it takes too much pressure to do that. And we know barotrauma could be damaging to lungs, so the ventilator kind of auto protects the patient. What's important to know in the asthmatic is they're so tight and they're so bronchospastic that the peak inspiratory pressure, which might be 40 or 50, probably doesn't reflect what the alveolus at the end of the lung is seeing. And that's what you're really worried about, is less barotrauma and more volutrauma. How much am I stretching those alveoli? And maybe I'm tearing and rupturing some of them. So what we can do on the ventilator is something called an inspiratory hold. And there's just a button at the bottom. You push inspiratory hold, and it holds the breath on inspiration, and it'll calculate something called the plateau pressure. And the plateau pressure in an asthmatic is often 15 to 20 points lower than the peak inspiratory pressure. And it really reassures you that you are not doing any volutrauma. The lungs are auto-protecting themselves because they're so constricted that the alveolus is not seeing that peak inspiratory pressure of 50 that you're worried about, may only be seeing 28 or 29. So the intubated asthmatic, that can be very problematic to manage, especially from a PIP standpoint, a peak inspiratory pressure. If you can reassure yourself with a plateau pressure, you're probably doing right by the asthmatic by giving them the appropriate tidal volume, the low PEEP, the inverted I to E ratio, and the lower rate, and you're not doing any barotrauma. You're not causing further lung injury. That's always a tenet. If you're going to put a breathing tube in, and Emily, even as a fourth-year medical student, already saying, well, intubating an asthmatic, I heard that might not be the best thing to do. Should we do that? She was right on point, that if you're going to put a breathing tube in an asthmatic, you have to make sure that you're not going to do further injury to that patient. It's very much like the trauma patient that comes in with a traumatic brain injury. That's already done. You can't undo that, but your job as the critical care doctor is to not cause further hypoxic ischemic injury to that injured brain that's already swollen and having a cytokine response and swelling and edema. So just like that with a ventilator, you can't undo their asthma immediately. You're going to work towards that with your steroids and your bronchodilator therapy, but you don't want to do more lung damage to them while you're mechanically ventilating them. So I know that was a lot all at once. Emily, I think you did an excellent job, and I'm open to any questions from anybody, Emily, or the panel at this point, and then I'll turn it back over to John, and hopefully we can show you around all the different places in Acadicus.
Yeah, that was awesome. I really appreciate you all having me. The only question I have is about the paralysis meds that we use for intubation. Can you you said it was rocuronium? So
there's depolarizing and non-depolarizing as a broad category. And the really only depolarizing medicine is succinylcholine. It's used in adults all the time, relatively contraindicated in children, and definitely contraindicated in children with MR and CP and seizure disorder and spastic quadriplegia because it can cause hyperkalemia and arrhythmia. So in pediatrics, we usually stick to one of three non-depolarizing neuromuscular blocking agents. One is rocuronium, 1 milligram per kilogram. Onset is 60 seconds and lasts about an hour. That has to be refrigerated, so it's not usually in code carts. If Jeff or Mitch was asked to get that, they'd go to the code cart. It's not going to be in there because it has to be refrigerated. What is in the code cart, though, is another non-depolarizing blocker, very similar to rocuronium, called vecuronium or VEC. That's 0.1 milligrams per kilogram, does not have to be refrigerated. Onset is about 60 seconds, lasts about 45 minutes, maybe an hour, depending on the patient. And then in patients that have liver disease, which we take care of, a lot of liver transplant patients, we use a drug also non-depolarizing called cis atracurium. And that drug is metabolized outside of the liver by a mechanism called Hoffman degradation by the plasma proteins that live in your bloodstream. So we know that liver patients are not going to metabolize ROC or VEC, and they're going to stay paralyzed for days if we give it to them. So we tend to use cis atracurium for those folks.
That is super helpful. Thank you so much for clarifying that.
Anytime. Other folks that may have questions about the mock code or Acadicus in general, John obviously is the expert and can jump in on any Acadicus questions. Okay, well, John, should I turn it back over to you for a tour?
Yeah, no, I really appreciate you taking the time to join us today and for running the code. Dr. Slamon, really appreciate your time. Also appreciate Mitch and Jeff for helping out. That was on very short notice. We got them in and they went in and had a rehearsal and we went through things. So really appreciate their time. Just want to remind everybody, next Friday, we also have another simulation. It's going to be primarily an EMS paramedic simulation. That's going to be, I'm just pulling up my calendar. I should have done this ahead of time, but Friday, it's going to be starting at 10:30. So if you look at our Discord channel, we've got more information and a link there. Otherwise, just email me. I'm at jon@archvirtual.com, john@archvirtual.com, and I can send you a calendar invite for that. So that's going to conclude the Zoom event for today. We're going to be going on a tour of some of the work that Jeff Zielinski and InHealth are doing. And we're going to be preparing that as a recording that we'll also be publishing to the website. So you'll be able to see some of the really cool stuff that InHealth has been working on and Jeff's been building. Really, I think some of the really pretty innovative stuff that he's working on there. So we're going to be showing that. And we're also going to have another Acadicus Impulse with Mitch Luker from NWTC, who was assisting today. He's got a lot of great insights to share, I think, about the logistics of setting up a lab and starting to get familiar with simulation and running simulations in the school. So we'll be hearing more from Mitch as well. So stay tuned, subscribe to our newsletter on our website, I guess is the best way to stay in touch. Otherwise, join our Discord channel. And otherwise, unless there's any other questions, have a great weekend, everyone. And thank you again for joining. Really appreciate it.
Thanks, everyone.